Nick Majerison here. Welcome to Top Med Talk, and today's Top Med Talk was recorded at the recent Evidence Based Perioperative Medicine, that's EBPOM USA conference in Chicago in 2018. And it's the Q&A session that followed the presentation by Matthew McEvoy, the Vice Chair for Educational Affairs and Professor of Anesthesiology at Vanderbilt University Medical Center. The presentation was The Opioid Crisis, Can We Kick the Habit? And here is the question and answer session that followed it. Have a listen.
Top Med Talk.
Awesome. Thank you so much, Matt, for the entertaining final presentation this evening. So we'll sit down. So again, please engage us on Slido, and we're going to try and hit some of these up early because I'm sure all of you have some really great questions, and those listening at home. And if we don't get to the questions tonight and some of the other questions that you all had, we're really happy to delve into those throughout the weekend on Top Med Talk as well. So we'll definitely be getting to those. So Matt, you know, your background at Vanderbilt, you've been an anesthesiologist there. And so, I mean, in Tennessee right now, you guys are dealing with this. And you're dealing with all your patients coming in. So what steps are you guys taking personally in your practice to address the opioid crisis?
So, great question. One, I would say that we are constantly learning. And I don't mean to say that as kind of a catchy thing, but we're willing to say, it's not going to be this recipe. You know, we are, I think there's lots of ways to approach the problem, and we have to be willing to say, I am really tied to better care for patients and reducing opioids where we can. I'm not emotionally tied to ketamine or lidocaine or my block or whatever, right? So I think that's the stance that we take. Some of the specifics, and I'll talk about some of them tomorrow, but we basically have an approach where we say that opioids should be on last and off first, and that multimodals should really be maximodal, and that those should be on first, scheduled, and off last. So opioids are on first, only as needed, and off last, and multimodals are on first, scheduled, and off last. And then that plays itself into the pre-op and intra-op arena, the PACU and initially being on the floor, and then our transition plans on the floor. Where the Tennessee doesn't lead in a lot of things, or a lot of the categories that you want to lead in. It is beautiful. Come visit. Nashville's a cool town. It's the number one destination for bachelorette parties, I believe. So we also consume a lot of alcohol in addition to a lot of opioids. But it's we see tons of patients who are on chronic opioids as well. And so we have a transition pain clinic. And so we really divide people into opioid naive, what we call exposed, and then tolerant. And if you're in that tolerant category, we do our best, just like you've heard already, of trying to get upstream of this problem and come up with a weaning plan pre-op, and then have a plan actually where they come back and see that clinic post-op.
So many of us here are not physicians, and so we're not necessarily in the prescribing area of this, but we're the ones that are doing the education and trying to, on the ground, working with the patients when we're asking them what their pain scale is, and choosing what medications we're going to give them when we have a vast array of orders to choose from. One of the things that I see as a problem, and I think we've had this conversation a lot, is the educational component for those people on the ground. And how are you guys working together with non-physician providers to educate them and get them up to speed and everybody be on the same page?
So I would say the partnership that we have with the frontline nurses in particular is, I think, good and growing. And you simply can't do this, particularly for inpatient surgery, you can't do this without a good alliance there. Because like you said, they're at the bedside, they've got a set of orders, they're making decisions, and it's very easy to stand back and say, well, why didn't you just do X, Y, or Z? Yep. When maybe much of their practice if you say that they've been practicing for 20 years, much of it's been opioid monotherapy, or at least you start there. And so I think we've really learned from their view that they feel very ethically bound to say, I've seen this work for pain, and I get that, yeah, there may be some nausea involved, or, they talk about ileus, but there's been a go-to thing, and so really spending a lot of time with education and partnership and collaboration to say, we are going to flip this on its head, but we need your feedback, and we also need you to tell us where the other things we're using aren't working. It's very easy to say, oh, we're going to throw in this big soup of lidocaine, ketamine, gabapentin, and all this, and really getting that feedback for boots on the ground, pragmatically, how does it work is vital.
Yeah. So one more question kind of related to that. And you addressed the pain, and pain is the fifth vital sign, and how that has changed the face of how we treat patients and their narcotic needs. And so, one of the things that I always ask some of those frontline providers is there a different way to ask that question and to determine? So, I mean, what are you experiencing with that? And
yeah, so we, one of the John Wander, a guy in our department, did an analysis of about 20,000 patients in the PACU, and it turned out that by far the most important factor with what a patient's pain score was the person asking.
Absolutely.
And if you go over and do a sternal rub and say, "Are you hurting?" You're going to get a yes. I think again, even flipping that question to either say, if you're going to use, say, the numerical rating scale, right? Mm-hmm. There's a validated way to do that. Walking up and saying, "Is your pain a 7 or more?" Right. Isn't the way to do that. The flip side is we just change the language and we say, "Are you comfortable?" And the truth is, there are some people who truly want us to do this, deep anesthesia for 3 weeks, and then they wake up and then they're out of pain. But there's a lot of people who are very reasonable and say, "I know that I had major surgery." I love the people who are 65 to 90. Who they just expect life to hurt some. Are you, and if you ask them, "Are you hurting?" They do. They say, "No, I'm sore, but I'm not hurting," and they distinguish the two. Yeah. And so if you ask them, "Are you comfortable?" or "Are you comfortable enough?" they're okay. And so we do flip it on its head there. And I think with that, we educate patients in ways that we try to take out our verbiage. We tell people, I actually had a bad headache earlier, and I asked Tim if he had any opioids, and he said yes. He actually only gave me ibuprofen, but they were in a pill bottle that I almost brought on stage. But for me, it was hurting bad. It wasn't in my realm of bearable at that time to come up here. And so we talk to patients and say, forgetting all the numbers and all that, like we care about that, but what I really care about is, is your pain bearable or unbearable? And we define bearable kind of in the DREAMS moniker, drinking, eating, that if your pain is keeping you from drinking, eating, mobilizing, or sleeping, then that's unbearable. Yeah. If it's not, then we call that bearable. We'd tell them we'd love for it to be a 0, but it's probably not going to be. And much like you heard today, that talk happens ahead of surgery, so that it's not when they're already hurting on the floor. And so I think, the philosophy we have, engaging frontline providers, and definitely you can't do it without engaging the patient, and particularly if they have a family member present. Yeah,
patient-centric care. I mean, it's all going back and setting expectations.
Yep.
Our expectations of them, and then reverse of that. Okay, so let's get to some of the. Oh, this is a good one. The first one that's come up here. This first question. Do we have it? Great. Get to our Slido questions here. So let's just jump right into it. What role is medical marijuana potentially playing in acute and chronic pain management? Is medical marijuana legal in Tennessee?
They have medical marijuana. We've actually found using Marinol for postoperative nausea and vomiting, and for some people with chronic pain syndromes has been of benefit. And so that has been something that makes it into our use a little bit. I would probably say on maybe 3 to 5% of patients, and in our patient population, it tends to be people who often it's actually our IBD patients who have had protracted pain syndrome for a long time, and with that GI dysfunction and often some complex nausea and vomiting. So that's where, for us, that's where we've made it into it. I think that I think that the answer is still out as far as firm evidence on how should we use that in a standard way.
Mm-hmm. Is anyone here in the audience using medical marijuana in their parts? I get this question a lot. Is it part of the ERAS pathway? No, not personally. Are you using medical marijuana?
Well, what it does is patients don't hurt less, but they're a lot happier.
Right? And they eat. Like, they're going to be nutritionally.
I think on enhanced recovery, you give them the munchies, and
they're drinking,
right?
eating. And all right. Questions from the audience. Great.
Hey, my name is Catherine Holwood. I'm an OBGYN from Charlotte, North Carolina. And I wanted to circle back to something you mentioned earlier, which is that you screen patients as to whether they're opioid naive, exposed, or tolerant. I'm very interested in how you do that, because that, if there's a verified, validated questionnaire, that'd be very helpful. I think we all suspect, the heavy drinker or the anxiety patient, but we may not be picking them up.
Great question. So as far as a description of that, one, David Edwards, who will be speaking later in the weekend, will talk a bit about how we have a transitional pain clinic, and two, where we're starting to do that there, and then trying to do a better job with our PEC, our pre-op evaluation clinic. We tend to, right now, and that's in its infancy, we try to focus a lot as an institution on med rec, and so that we're getting that right. And we're an informatics-heavy department, and so what we're trying to do is be able to identify that person who, based on their med rec, is going to have a certain number of MMEs. And there should hopefully be, I would hope in the next 6 months or so, a paper coming out describing just that, this naive, exposed, intolerant breakup, which is naive. You haven't had any opioids in the past 90 days. And the reason that was picked by the group that developed it was you could have had a colectomy, you have an ostomy, you went home with a reasonable prescription, you come back 6 months later, you're having your ostomy reversed, you appropriately used opioids, you've weaned off of them, you're still opioid naive, right? Then there's the exposed, which goes into some of the CDC definitions of where tolerant would come in. Tolerant would come in at more than 60s per day. And so if you want to say, well, what is 60 MMEs? It's 4 oxy-10s a day, right? And so if you're between 1 and 60, then we call that exposed. If you're over that, we call that tolerant. And we try to really focus on those folks. In our practice, quite honestly, you have to be over 100 MMEs a day before just by volume, before we're ever going to move into a weaning type of opportunity. But even in its infancy, we've had some real successes with patients who are on, 150 to 250, 300 plus MMEs a day, getting them in the clinic, getting them on multimodals. They're coming in for major abdominal surgery and having not only a weaning plan towards surgery, but then while in hospital, what's going to happen, and then how do we pick them back up post-op. Did that help? Did that answer your question? Yeah. Okay.
Actually, I wasn't going to say this, but I'm going to say it now. I know later in the week there are a couple talks specifically, one by your colleague at Vanderbilt, you think Dr. Edwards, who you mentioned, and I think also Dr. Padma Galur are going to specifically speak to the process and our, if you will, recipes for dealing exactly with that question. So look at your agenda and be sure you attend those courses. It's a cool area. My question to you, Matt, it's sort of a baiting question, but I think it deserves some discussion. What, in your opinion, do you think is the contributing forces of the performance alignment with HCAPs that physicians are having to manage to? And so link for me, if you will, HCAP scores in our aligned performance metrics as physician providers with the crisis.
Well, so I think there's the concept of, was my pain adequately treated? How well did the team actually? They ask, was it adequately treated, and how well do I think the team attended to my concerns? They don't ask, was your pain score less than 4, which is really important because it gets into communication education. And there are times when we have people who are the chronic pain players who, say that they live at an 8 or a 9 and they were there the entire time, and walking out the door, they say, thank you so much. And you say, if I lived at a 9 for 3 days, I'm not sure what that would mean. But, and so I think there's this fear that if we go this other route, we're going to get a lot of dissatisfaction. We've got a kind of unique setup at our place because we follow all the patients that we do ERAS protocols on post-op, and the anesthesia perioperative team actually controls all their pain management until they're on a stable regimen, and then we hand that to the surgical team. And a lot of other places do it and successfully in other ways. But what we have found is on the services and the units where the patients go that our periop consult service rounds on those patients, the HCAP scores went up. And we think that is the engagement on the one hand, we know their in-hospital opioid use went down by over 90%. And this is going from a rate of PCA of 94% of patients getting a PCA to now about 3%. And so huge reductions. And yet I think it's a lot of the engaging the patient, engaging the nurses who are providing the bedside care, because they're a huge interpretive force for what's going on for the patient and the family. And then the fact that multimodal does work. It's not just that we're leaving people in pain, but it isn't. It's one of those things that pain scores really stayed about the same and our opioid use went down. But it is a big concern. And I think talking to my surgical colleagues, I mean, one of the number one reason that they send patients home with long prescriptions of opioids is the number of calls they get and whether someone's going to be satisfied with that aspect of their care, because there's other big portions of their care as well. So I think it's a reasonable concern. People, you do this paradigm shifting and they get concerned about, am I going to now get reported in some bad way? Our experience has been just the opposite.
Matt, it's Mark again, and I enjoyed your talk very much, other than the fact you reminded me that you were a student when I was an attending.
This is one of the faculty who trained me.
But you talk about we and you talk about crisis and the fact of who is the we. We have practices, and I'm with North Star Anesthesia, we have practices in West Virginia that suffers from the same opioid crisis. Some of my surgical colleagues, some OBGYNs, because of the state regulations that are being oppressed upon them and the amount of paperwork that generates, so instead of just giving a few opioids, they're giving 3 days of 2 Percocets every 4 hours. So now all of a sudden, just to avoid the calls at night, as you say, they're giving 36 tablets to somebody that may not use 2. So my question to you is, we're probably the we that should be involved. With a crisis, the government and all their wisdom feel like they need to be the ones to help drive the changes that are the opioid crisis. What role do we play in helping to help these guys to make sure that what they think is the right answer may in fact be worse for the problem?
Great question. How many of you practice in a state that has a law on the books as far as the number of days? Okay. How many of you can opt out if it was major trauma? Okay. So one.
No, he don't. Yeah, I don't know.
Okay. So Tennessee just had a new law go into effect in July, and we have the 3-day rule, and then there's a rule if you're a chronic pain patient, that's established. But there's this out clause if it's major trauma, and they didn't define what major trauma is. And it actually is written loosely enough that if you had cataracts taken out, you could have had major trauma because it was surgical. But you have to document it. You have to check basically the CSMD, Controlled Substance Medicine database. So there's some things you do have to do. I think we've got to educate our policymakers, right? Mm-hmm. Someone once said that the most likely thing for a drunk person to do after falling off of one side of the horse is to get back on and fall off the other. and I think we've got to be really careful that the cure isn't worse than the problem. Because what you just described, I know is happening in Tennessee, in South Carolina, and in Georgia, colleagues I've talked to there, which I don't know if y'all picked up on this. The way you described it, so there's a 3-day rule. You can't write a prescription longer than 3 days. So you think someone might need to go home and take 1 Oxy 5 every 6 hours, for 3 days, fill quantity sufficient. It's take, 2 to 3 pills every 4 to 6 hours, and they say that's the only way I can get you more. So now the patient goes to read the bottle or the family member, and they forgot the education that they may be taking 3 times as much as they need. And so, but in order to get the pill count right for what you want, you're doing this workaround, and yet the explicit instructions to the patient are going to be dangerous. And so every pharmacy will have something. If you say take 2 to 3 pills. They have to fill to the highest number of pills and the shortest frequency so that they could fill the quantity sufficient, unless your state regulation also limits the MMEs. Ours is down at the very low level of 850 MMEs per prescription, so still enough to make a lot of money or do harm to yourself. But so you're exactly right. So I think we need to educate policymakers. I also think everyone is currently focusing on the opioids. We just did a thing where we've got a technology that through either email or SMS texting drives a question a day out to folks, and we just enrolled 1,200 people in our institution and did an educational intervention using what's called spaced education. And we're looking not only at did our MMEs per prescription go down, but did our number of scheduled, ordered multimodals go up? Because I do think that's important. I think it's a very real thing to say, yes, 70% of the pills that go home don't get used, but even so, until we get this right and until we really understand how to do dynamic prescription writing based upon the MME consumption in-house, we also need to replace some of that. And, yes, you have to be careful with gabapentinoids, but we often do a 10-day to 2-week taper on gabapentin with people. We use scheduled Tylenol, scheduled NSAIDs, and with those 3 alone, you can take care of 70 to 80% of pain. In fact, most of our patients after colorectal surgery don't take any opioids after going home, and they take very minimal while they're in the hospital.
Yeah, it's interesting that we're talking about making sure that we schedule those things, because that doesn't, especially when you're starting an enhanced recovery program or something like that, you don't think about scheduling, just give it a PRN. And then when patients go home, though, it's another kind of educational piece, because I don't know if you've ever had to do it, but like trying to remember, am I supposed to be taking ibuprofen or Tylenol? And then you kind of get confused about what it is, and then trying to describe how to do that to someone is technically sometimes a little challenging, and it gets off kilter very easily. So.
Yeah, so we've worked on that you've got if you have a patient educator, most hospitals will, and make sure that it's to the appropriate reading level and all those sorts of things, that doing stuff, if you want to see a really good example of this, if you look at the McGill website, they've got some great just infographics for how a patient should move through, and it has pain and diet and all these other things. And they said, people are free to use them. We mimicked ours off of theirs because they were so well done, and patients said, yeah, I really like this. And so having a sense just that these are scheduled, take these as needed, and things that if any of us say to each other, okay, take this on a scheduled basis, take this on a PRN basis. We know what we mean, and we're just so comfortable with that we don't realize how much that gets lost on a patient.
Yeah, patients have no idea. Let's go to Slido again. And this is a good question. Why is the problem so acute in the U.S. as opposed to other countries? Should we ask our colleague, or our British colleague? Well,
they would just say that they don't care about people.
Yeah.
That's not true. I believe with how many of you have read Dreamland? Okay, one. Go get Sam Quinones' book on Dreamland. It's a phenomenal book, and it tells the story of black tar heroin and medical pharmaceuticals. It's worth the read, and Sam's a great guy. And if you say, we have a real problem at our place, you can get him to come speak to your place. It's phenomenal. It's put in the version of, not technical language, but people language. And I think he describes it really well. We have an overprescribing problem. Industry is not all bad, but in this case, there was a lot of industrial pressure, plus patient satisfaction scores, plus this whole thing that I'm sure no one ever intended, but came together, and for that whole perfect storm between we're now being graded on patient satisfaction. Pain is now the 5th vital sign. There's these great, opioids are really good for treating pain, right? I mean, they work, it turns out. So for us, if you look at somebody and you said, hey, I push a medicine and they quit hurting, it's got a great, learning effect for us that we say for pain, they're great. And I think it came at a whole decade of time where we then weren't looking downstream and didn't know how to ask the downstream question. So, it's and I think that other countries in the world didn't have the same problem. If you go to Africa, I know the work that I do in Kenya, they're deathly afraid of opioids from opioid-related adverse events from a respiratory standpoint. because they just don't have the monitors perioperatively that we do. So they've avoided it for a different reason. I don't know what Monty and Mike would say from the UK, but I think there's different cultural forces that drove it.
Yeah. Is it becoming an issue in the UK? Uh-oh. We got a mic. I think he's got the mic.
I've got the lavalier working. I think it's on the increase, but I think culturally, I think it's working now. But I think culturally, as Matt has described, we've been in a very, very different place. So we did have a period of time of this idea of the fact that you should make pain the fifth vital sign, and that's had a deleterious effect, I think. But we've typically been much meaner with our prescriptions and access to follow-up prescriptions because of our smaller country, geographically more accessible, and almost immediate availability of general practitioners and the greater tolerance of follow-up prescriptions through our pharmacists, etc. So we've made a direction of travel is the same, but it's a tiny problem, relatively speaking.
I'd just like to comment on
No, go ahead.
on a slightly different problem. I think as we try and get over this crisis, there's some difficulties in how we manage that. For instance, there are a lot of patients who are on chronic opioids who are now going to their pain provider or primary care provider, and they are no longer getting the opioids. They've been weaned off incredibly quickly to try and get them off opioids, and then these patients are turning to the street to get their opioids that they need, and then getting these synthetic fentanyls and dying with overdoses. I don't know if you're seeing much of that where you are, because I think it's going to be an equally challenging problem in the midst of this crisis, how we manage patients on chronic opioids.
Yeah, so it's a great point. So I think everyone in the room, as you mentioned, so we have nurses, advanced practice providers, anesthesiologists, surgeons, that all of us really need to understand, and back to Mark's point, that we need to educate our policymakers, and we need to understand the system. How many of you have drug monitoring programs in your state? Prescription monitoring programs, right? So you need to know how that really works, and you need to know the data they get, and you need to reach out to those folks, because a big question is, there was a paper that came out last December that said ERAS is wonderful, it's great, and all this stuff, and it led to a decrease in in-hospital opioids, no change on prescription. So we do need to educate people, but then we need to educate the patient, we need to educate everyone in the care team, and we need to think about then what's the data source for seeing what did we do long term. And that's going to come from those prescription monitoring programs, because the patient may not come back to, the surgeon may say, that's it, you get one prescription and I'm done, but then they're going to go somewhere else. And those programs also, I know in Tennessee, they track heroin-related deaths. They have a huge education program. You could imagine the stigma associated with this, right? And so for every opioid-related death that's reported, there's probably 2 to 3 that are coded as something else, because a family in some small town thinks of a stigma associated with that and doesn't want it coded that way. So to your point, it's a huge problem, and we need to make sure that as we're doing this, we don't turn people to a worse source, which the drugs coming from the street are very dirty and are exceedingly dangerous. And so I think we've got to widen our scope. It's not, yes, actually the patient doesn't. How many of you are anesthesia providers? Okay, keep your hands up. Everybody, real high. Okay. How many of you give the obligatory opioids on induction? Okay. So it's, right? You realize that it's not like the endotracheal tube needs to be laced with some fentanyl because you just can't put it in without it, right? How many of you, is it common practice where you practice that you got to give a little opioid before wake up just in case? Used to be? Is that changed? No? That's awesome if it's changed, right? But those are the simple things that we can do. But then we've got to expand our scope to say, as we begin to make all these sequential changes, and hopefully patients' requirements are less, we're still going to have the chronic patients. And what do we do with them? And think about that at a much higher level.
Yeah. Yep. One question.
So I'm Mohammed Jaffer. Again, I think you hit the target. If you look at the number of deaths in the United States from opioid overdose per day are happening, most of these are, more than 75% are less than 60 years of age. people. And people who are having surgical procedures, they are actually the other side, a lot of them. So there is a big problem in the society that we have as a whole, not only as healthcare providers, but also as parents or the school teachers. Or we need to target the society right from the beginning to reduce these deaths. I don't think we will be able to, change anything unless we go back and see why these things are happening. In the society, what we have done, we have given them just Narcan. Hey, here is the Narcan. If you see somebody overdose, give Narcan. What we did actually in my previous institution, we looked at daily Narcan use in the hospital. And just looking at that, we were able to identify the problem because people were using 2 or 3 opioids, one oral, second IV, and a PRN opioid as well. And we were able to cut the number of PRNs. If somebody is taking PO, no IV opioid, and you will see drastic improvement in the number of Narcan use in your hospital. And these are the things that we, as healthcare provider, actually in the hospitals, we can do to reduce the number of opioid-related deaths or complications in the hospital.
So I think that's systems thinking, and that's terrific. So in Tennessee in 2015, the number of opioid-related deaths exceeded the number of motor vehicle collision-related deaths. Now, that's actually reported death, so it probably happened before that, because we know of every motor vehicle collision death because no one's afraid to report that, right? And if you think about, if you just get in a crash, the emergency response system that we have and the resources we bring to bear. So back to Tim's point, when we think about the chronic users and these other things, these sort of one-size-fits-all and we're just going to stop the supply, it doesn't work. But if we look at other areas in society of where do we bring huge resources to bear, even if there's no injury yet, we need to think like that. And systems-level thinking at the hospital system, your community system, I would encourage you, how many of you have children in K-12, kindergarten through? Go to their school. Have a talk. I mean, Narcan in the communities is one step. Educating people, There should be no kid who dies in high school from an opioid-related overdose, and we shouldn't stigmatize it. And so this is a huge problem that we have to deal with, and systems thinking is huge.
We have time for one more question.
Sure. Miguel Morello, I'm an anesthesiologist in Michigan. So my question is that we've been focusing just on the anesthesiologist or maybe the CRNAs or whoever is managing the perioperative period of pain. But the other part is the nursing in the PACU. For example, I see a lot of them come to me with a patient that seems to be okay, but before discharge they come and say, Dr. Murillo, can we give a Norca for the road? And I go and say, is the patient complaining of pain? Like, no, it's fine, but it's a long ride. And I say, well, he should be fine. And then I get this stern look from them like I'm a jerk, And there's a lot of pressure for them as well. And I don't know if they're being also brought into this equation because absolutely at this point they're being enablers of this phenomenon. And I don't know what your experience is.
So first off, you simply can't make the headway you need without your nursing colleagues, which I don't hear you saying anything against that. But I do think that there's it's a long ride. And you say, well, do you typically take narcotics before you go on a car ride? No. Yeah. So what is the no? But you say that, right? But the concern is they're going to get in some crisis, and I think then doing the education to say, maybe they've had a block, they've had other scheduled multimodals, they've had their prescriptions filled out. How many of y'all have like a meds to bed sort of thing where they can get their prescriptions before they leave? So I think all of those things, and you say let's appropriately educate. But, the concept of preemptive analgesia with opioids has been disproven, right? And so the idea that we need to go ahead and use a dose just in case because they'll be better isn't true. We should be using their scheduled multimodals, and then they have a PRN if they need it. But I agree with you, and I think that happens a tremendous amount. And what happens is it's all those fractional things that add up to a lot of opioids consumed while in hospital, right? And we have to get at the root of those behaviors and then educate around them. But it's not easy. It's pulling weeds. And then what's going to happen is you're going to have people leave, and you're going to get float nurses, and you're going to have to do the education all over again.
Yeah. Well, I think it's the topic of your talk today. Can we kick the habit as the providers? And so I think this is a great conversation to have about it, and that's how we're going to start addressing it. So, Matt, thank you so much.
Yeah, thank you.
So if you enjoyed that piece, you will notice that some of the questions were sent in from the audience. No, not the audience in attendance at the event, but actually the audience who were listening online. How do I do that, Nick? I'll tell you. You get yourself to topmedtalk.com and then you click on the live stream and you can listen to us as and when we're broadcasting live from the conferences that we attend. But how would I know when they were on, Nick? That's the next question you're asking. Simple. Get yourself to the website and sign up for the email updates. Once you've done that, you'll get all of the vital information regarding your favourite medical podcast as and when we can send you it. So you'll be able to know where we are, how you can meet us, and how you can listen online. Make sure you sign up for regular email updates. Also, of course, don't forget to subscribe to the podcast, find us on social media, and finally, check out the EBPOM website, ebpom.org/meetings, to find out more about some of the conferences that we will be in attendance at. That's ebpom.org/meetings.